So the next title is laparoscopic sleeve gastrectomy in patients with a body mass index of 30 to 34.9. Dr. Berry and the group from Clinique Las Condes in Santiago, Chile.
Good morning. Thank you. I'm going to present our experience with BMI 30-35. This is my disclosure. Laparoscopic sleeve gastrectomy is a relatively new procedure. It was initially described, as has been said already, as a part of and combined with the duodenal suite in 1998 by Marceau. It was done by laparoscopy first by Gagné in 1999, and has become the most widespread procedure in our country and also mainly in South America, with excellent results and weight loss and acceptable morbid mortality. The aim of this study is to analyze safety and excess weight loss in the midterm follow-up of patients with BMI under 35. I have to mention that we do consider candidates for bariatric surgery in our institution for patients with BMI 30-35 if they have failed several attempts of medical treatments and they have at least 2 comorbidities. So I'm going to show the results of this prospective study, not random, between 2007 and January 2010 with a follow-up up to 12 months. I'm going to show you the analysis of gender, age, weight, pre-op, BMI, OR time, excess weight loss, surgical complications, and morbidity and mortality. These are our results. Most of the patients are female as usual, and a total of 184 patients with a mean age 39 years old, young patients. The mean pre-op weight is 91 kilos, mean pre-op BMI 33.3, that's a range, 30 to 35, mean excess weight of 22 kilos, and the operative time is almost 90 minutes. We combine with other procedures such as lap coles. 5 of them had a band removal in addition to the sleeve, and 19 of those cases, about 10% of them, we repair a hiatal hernia. These are the results. The weight loss at 6 months is in kilos 19, and 12 months 23 kilos. And if we look at the BMI, the pre-op was 33, at 6 months it came down to 26, and 12 months they're all within 20-25 range, an average of 24. So we have a very impressive, but these are our results, 90% excess BMI loss after 1 year. And if we compare this with the higher BMI patients, this is better. This is our morbidity and mortality. 7 out of 186 cases had morbidity. This was our morbidity, 7 patients, 3.8%. 6 of them had bleeding. Of those, 2 required transfusion, 1 a re-op, 1 had an stenosis. This was associated with a band removal before, at the same time, and there was no leaks in this group. No conversions and no mortality. So in conclusion, we can say that laparoscopic sleeve gastrectomy is a safe and reproducible technique in patients with BMI under 35 with a low morbidity and mortality. In our series, these results are very encouraging with excellent weight loss in the midterm, and of course we need a longer follow-up to show long-term results. Thank you.
Thank you very much for a succinct talk. I have a question that concerns a little bit about your surgical strategy for band removal. You had 1 stenosis after band removal. Do you routinely remove the band and proceed with a 1-stage procedure, or how do you decide?
If the patient come to a revision for inadequate weight loss or problems with the band other than sliding a band, we do at the same time, at 1 stage. If they do have slippage, we do it in in 2 steps. And in that patient, we had a problem that he stayed for 7 to 10 days because it didn't open up. And after that, we start taking out also the capsule where the band was. And that was a problem in that case.
Okay. As concerns hiatal hernia repair, about 20% of your patients, do you repair the posterior crus or do you repair the anterior crus? And if you repair the posterior crus, how do you approach that? Because if you go on the lesser curvature, you're worried about devascularizing the esophago-gastric junction on the lesser curvature.
Yeah, we look, always we look at the pre-op study if the patient they have a routine endoscopy. If we do know that they have a hiatal hernia, we do repair it. If not, we look for, and we always repair anteriorly. We don't go posteriorly, unless they have a large hiatal hernia that may need also a mesh. In that case, we can do it posteriorly.
3% of your patients were band removal patients.
Yes.
What was their original BMI? Were they total failures, or were those successes that just had a complication? And the second part of the question is, did they eventually behave differently than the patients who didn't have an original failure?
Yes, we have a different study. We look at that conversion from band to sleeve gastrectomy. We have about 40 cases so far, and they do well in terms of weight loss after that. Most of them have become successful within the first year with the band, and then start regaining weight or start having very poor quality of life. In those cases, we think that the sleeve is a good option, and we remove the band and do the sleeve at the same time.
But did that group, if you separate that group out from the others, was there a difference in weight loss? I mean, so that the group that didn't have some other procedure did better, or did the same?
Actually, it's the same. Yes.
One last question. Do you have any absolute contraindications to sleeve gastrectomy in that group or any other group?
Yes. In patients that in the pre-op study we find a severe esophagitis with ulcers, grade C esophagitis, or a Barrett, we do recommend to do a gastric bypass, even in the group with BMI 30 to 35. With the Barrett, we do a gastric bypass.
All right. Any other questions from the floor? Thank you very much for your presentation.
You.